Yes.
Just making sure. All right, we're recording. We are recording. All right, so this first one here, I'm going to put the video up. It's something you as a MA probably will never have to deal with or see. And, but I always put it up because everybody always wants to know about it. They're like, what is it when they shove a needle in somebody's heart? Because you see that in the movies and stuff. Um, Unlike Pulp Fiction and that, where they put the needle in the heart just to give her the epinephrine. Wait, that's a no. But there is a time where a doctor may take a needle and place it into somebody's heart, and that is when that there is excessive blood or excessive fluid around the layers or of the heart, and it causes what's called a cardiac tamponade. And so this video will explain it, but it's not like what you see in the movies. Most things dealing with the heart are not like what you see in the movies. The next thing we want to talk about, though, is cardiogenic shock. Okay? Now, unlike our other types of shock that we've talked about, cardiogenic shock is going to usually come on rather fast. It's going to come on um, in a much more rapid appearance with its signs and its symptoms than other types of shock. Okay? Um, so, what you might see, especially with this one, I've seen people who were, doing fine, talking this and that, and then all of a sudden grabbed their chest and they were, pulled over. Um, People experience rapid breathing all out of nowhere, or shortness of breath, um, uh, having a normal heart rate, and then all of a sudden just having their heart race, like extreme tachycardia, uh, uh, being fine to loss of consciousness, weak pulse, sweating, pale skin, cold, clammy. Um, there's a medical term we call for somebody who's very sweaty on the skin, as we call them diaphoretic, and the sweating is diaphoresis. So if your patient is uh, real sweaty feeling, that's another term. Um, and then some people have warning signs where they're not urinating, and that's uh, an early sign. But cardiogenic shock's always one of the scarier out of all of the shocks, because you usually have less time to try to prepare the patient, save the patient, that kind of thing. So, and it's not something really as an MA that we're capable of dealing with, but we can watch out for them signs. And I'll let you know one of the first signs that you might see as an MA is somebody who goes looking. They walk into the office and maybe they just don't look right. You're used to seeing Miss Jones, and she comes in, and then sudden she turns ashen or gray looking, or their skin color. Our skin is usually, I told y'all this when we learned about integumentary, our skin really tells us a lot about what's going on inside. Um, I've seen, and people say, well, how do you tell if somebody's black? If you're black, there's absolutely no difference. You'll notice, it almost looks like whoever goes into cardiac shock, no matter what race they are, it looks like if they have a shine or a glow up in their skin, it disappears and they become ashen. And until you see it, you won't know what I'm talking about. But it's very apparent. That's a sign you look for. When somebody rapidly changes in front of your eyes, that's something to alert you. That's something that you should be like, whoa. The cyanosis, that should be something. And then the breathing and that kind of things. So there's not, and like I said, unfortunately, there's not much we can do. Um, you as an MA, you're going to get the doctor. And depending on the protocol of your office, like wherever you go to work, they'll have protocols. Um, if somebody passes out or somebody has a unconscious or a heart attack, or, you know, we always get Dr. Miller first. Or no, we always call 911 and then get the doctor. So you will have, and you need to know that. That's something they need to train you, is what do I do if this happens? So you make sure that you get that proper training. Um, but what normally happens for this patient is they'll need emergency life support, most likely blood thinners, a stent to repair their heart, possibly even heart transplants. Because cardiogenic shock means basically that they either have a massive blockage, or their heart has stopped, or there is, and it could be from some other system failure as well. But there's something serious, something underlying. So it's an emergency situation. And then our next thing, and this is a term you need to know, carditis. And then that should be pretty easy. With cardio, the heart, right? Itis, we know is what? Inflammation, right? And there are three, and I want you to write this down. There are three types of carditis that we can experience. And that's because of the three layers of the heart. And y'all didn't think those heart layers were going anywhere, right? So they're not. You can have endocarditis, myocarditis, and what would myo be? Somebody wake up.
The muscle.
The muscle, yes. And then the pericarditis. All right. And these can usually, most of these are due to infection. A lot of the times it can be viral, but here, not so long, we've learned that is it endocarditis or it's one of these two, that it's actually when you go to have dental work, that the bacteria, when they're cleaning your teeth, has led to people having this. And so that's why they're real cautious now. And they put those dams in your mouth if you've been to the dentist. And they really make sure that they block and they keep anything from going down and you from swallowing any while they're cleaning. Because used to, in the past, they used to just go ham and water was splashing, you were swallowing things. It's not like that anymore, because they've realized that that can be a cause of it. And then we answered this: myocarditis, inflammation of the heart muscle. All right, so the next, and y'all can go back and you can write these down if you'd like, but it's, as long as you remember the layers of your heart, you'll be able to remember. The endocarditis is the inner lining, and it's like I said, bacterial. Myocarditis could be an issue from a viral infection, and then pericarditis is usually either a heart attack or viral infection. Okay. And then we went here. All right, the next thing I want to talk about, and this was a SurveyMonkey question: coronary artery disease, CAD. So y'all should already be experts with this, because this was today's survey, wasn't it? I think it was.
Yeah, we had it today.
Okay. Coronary artery disease, or CAD, basically means that you begin to have, over time, that blockage, the plaque we talked about, or the fat, that begins to build up in the vessels. It causes narrowing of the vessels. It causes weakness of the walls. It can cause all kinds of complications. And if it gets too severe and blood can't flow like we see here, then what's going to end up happening is the patient's going to end up with some type of occlusion or blockage. 1 second, I have to tell Siri. Hey Siri, set a timer for 2 hours. Sorry.
Okay.
The patient might, when that final blockage begins to be just too much, they might start having symptoms like a heart attack. They might have lightheadedness and sweating and chest pain, shortness of breath, and a rapid heartbeat. So you see a lot of these symptoms kind of carry over from one disorder that we're talking about to the next disorder. But what causes CAD? CAD, and this is the coronary artery. This is not just any artery. This is the artery. This is the heart's artery. You know, so we have to keep this artery well. But things that can damage it is smoking, hypertension, hypercholesteremia, that's high cholesterol, right? Diabetes, and a sedentary lifestyle. And it should be up here as well as obesity. So all of these can lead to this coronary artery. And let me go back, make sure that y'all realize that the coronary artery, that is the vessel, that's the main one for the heart's blood supply, right? So it's not like it's a vessel that runs throughout the body, right? It is the heart's designated one of the main blood supplies, all right? Does that make sense? And then congestive heart failure. Now this you've probably heard of before, CHF. If you have somebody who's real old in your family, a lot of old people end up with CHF. It's a chronic, and what does chronic mean? Somebody besides, I can't think of her name.
Melina.
Melina, yeah, somebody besides Melina. What is chronic mean?
For life.
Yeah, it's long term. It's happening. It's something that's carrying on. Exactly. And acute, the opposite of it, means it comes on rapid and sudden. But something that's chronic, that's something you're going to be dealing with long term. And basically what ends up happening with a patient is their heart just begins to get weak. It begins to be lose the ability for it to pump, lose for the contractility, the being able to, squeeze properly and pump properly. And the issues with this is we see the patients starting to have shortness of breath. They look swollen. They really start looking kind of puffy looking, especially in their legs, their lower extremities. And then in severe cases, it might start looking that way in their face and other areas of the body. One of the things that we can do for CHF, because we know it causes fluid retention, is we can tell the patient no salt. You got to eliminate salt. But telling a old person to stop doing something they've been doing is really hard. Limiting their fluid, giving them a diuretic to make them pee more often. And then sometimes they'll help them out. They'll implant a pacemaker. and it'll be able to help with the contractions of the, the beating of the heart, to continue to keep it active, to continue to keep it regular. But the main thing that you should get from CHF is that the heart is just tired, and things are backing up and building up, because our heart and our lungs, we know, are their best buddies, and the circulatory system. So if the heart's not moving everything around, the kidneys aren't as filtering as well, everything's kind of slowing down. One of the first things that we notice with people with CHF is they start having a cough. They start, and like I said, that swelling in the lower extremities. And that's because of all that excess fluid. So the treatment usually is just to maintain the fluid levels, keep that heart from becoming overworked any more than it already has been, and maintain the fluid levels. So that a lot of times I've heard patients who've had CHF complain, it says, when you lay them down, it feels like I'm drowning. I can't breathe properly, or I get a heaviness and that kind of thing. So they like to be, a lot of times, that orthopedic positioning, keeping them laying and setting upright, helps as well. All right, then the next thing we're going to move on to is myocardial infarction. And everybody should know what this is. This is a heart attack. And myocardial, the muscle layer, infarction, it means block, lack of flow, or death to, if not corrected. And we abbreviate this MI, right? This is a medical emergency. And I'm going to talk to y'all more about this, because what we notice with a lot of patients who have either just recently had an MI or having an MI is, how we talked about the P, the QRS, and where's that T supposed to normally be? Down here, huh? Well, this is what we see a lot of times with patients who are having a heart attack, is an elevated ST. Because see where that S is? Shouldn't that S be down here on the line? And shouldn't the T be down there? But that's not what we see. When people are having MIs, we'll see an elevated ST. This should be something as an MA that if you spot, and it's not something that is like, oh, maybe it's just a fluke or something like that. If you got your leads on correctly, you've done the proper placement, and you see this with your patient, this should be something you circle and maybe let the doctor know. Hey, this is Mrs. Jones in the room, right? Poor Mrs. Jones, we're always picking on her. But symptoms, and most of us are familiar with these classic symptoms of a heart attack. What is in every movie and every show we see? Patient starts, they're grasping their chest, right? And then what else? They're saying maybe pain that radiates in their jaw and down the left arm, right? Those are ones we've always seen. But we know that is what we call typical for men. Now, women, on the other hand, women can still have those symptoms, but it's what we have found out over the last 25, 30 years is that women usually have what we call atypical symptoms. This means that they're not that classic. What we see with a lot of women is we see anxiety, we see upset stomach, a complaining of like very nauseous. We see lightheadedness. we see them complaining of a heaviness in the chest. So they're not typical symptoms. So that's why whenever, when I was a paramedic and I had a woman who, that's what she called me there for, I'm gonna be a little hesitant. I'd always hook them up to an EKG just to be safe. All right, because, so like I said, a lot of times women do have those atypical symptoms. Treatment for an MI, treatment is going to be one of those. When you have a heart attack, and you survive, the doctor is going to be, all right, you've got life choices to make. All right, and they're going to sit you down, they're going to explain to you, they're going to be talking to you. If you're a smoker, that's it, you're done. There's no more smoking. If you're overweight, you're going to drop weight. If you have high cholesterol, you're going to get that under control. If you're diabetic, you're going to start watching your sugar better, because we know these are all things that lead, to a heart attack, right? And I want you to get into the habit of saying MI, myocardial infarction, okay? I want you to be familiar with that, and that's how a lot of the medical field, they're going to say the patient had an MI. So instead of, a heart attack, okay? So get familiar with that. I have a little video that I'm going to play for you, or put into Teams, and it's going to talk about a myocardial infarction, and it's a little cartoon, and it's actually really informative. If you did not know, this is something that I want you to write down as well: cyanosis. And I think all of y'all got that definition down, as much as we talked about it. But cyanosis is anytime we see bluing or purpling discoloration of the skin, either in the lips, the fingertips, the earlobes, the newborn's toes, stuff like that. Okay? And then we're going to move on to cardiac arrest. This is where there's a really, really, really big difference, okay? And so many people get this confused. A cardiac arrest, an MI, you still have a heartbeat, okay? You still have a rhythm. You see the rhythm? With cardiac arrest, there is nothing. There's no heartbeat. There's no rhythm. There's no breathing. There's no consciousness. It is considered the patient is dead. That is a clinically dead. But cardiac arrest, if it's true cardiac, like for some underlying cause, a lot of times can be corrected. We can have patients go into cardiac arrest because something as simple as they've been vomiting the last 5 days and they're so dehydrated, their electrolytes are completely out of whack. And so little things. So it doesn't necessarily mean that it's has to be permanent. I have seen people who have been clinically, or what we'd call dead, who have been brought back because of it was something like a sodium imbalance or potassium or electrocution, different things like that. So, but what I want you to make sure you understand the difference is that a cardiac arrest is not an MI, okay? An MI still has a heartbeat, still has a wave, and a cardiac arrest does not, okay? Usually this person is going to need immediate life support, CPR, and this is why they have the AEDs everywhere, and they're able to, if possible, help this patient and get this patient to a medical facility fast enough and be able to reverse the underlying issues that caused cardiac arrest. Okay, now if it was that the heart just gave out for whatever, some unknown cardiac issue or defect or something like that, that usually is not something that can be fixed or corrected. All right, let me see where we're sitting at with time. Oh no, we're fine. Okay. All right, so we're going to go into hypertension. And how many of y'all already knew that the abbreviation for hypertension was HTN? Everybody should have known that. All right, and if you didn't, that's something you should be jotting down. All right, we know that hypertension, how many disorders have we looked at that one of the causes of that disorder was related to high blood pressure or hypertension? Like, how many? Give me a percentage. 70? No, it's more than that. 80? No. Probably about 90% of a lot of this, the disorders we're talking about is due to hypertension. I got feedback. Whoever turned that.
It was
You gotta,
me, Elizabeth.
oh, sorry, you gotta mute it because I can. It's echo. High blood. Hold on. Go ahead. Mute yourself real quick for me. I don't know if y'all heard it or not, but I heard it. Show me. All right, so let's talk about high blood pressure. If y'all have a question, stop and I can stop talking and then I can answer you. High blood pressure, a lot of times is really scary before you're diagnosed because you could be walking around having an incredibly high blood pressure and not have any symptoms. Some people are asymptomatic, but fortunately, there are usually signs and symptoms with high blood pressure. But you know what? We're human, and you know what we are? We're stubborn. And a lot of times we overlook them, and that's bad. But I'm going to tell you some.
I have a comment. It's called a silent death.
Yes, it is. Absolutely. Because high blood pressure can literally sneak up on you and you can have it. And it could be so severe that, yeah, you stroke out. You have a heart attack from it because it's undiagnosed. It's silently been killing you for a while. That's why it's important to go in, to have your physicals, to have your yearly. If you're having any kind of symptoms, to get seen, to get checked out. And some of the symptoms might be not what you expected. What if I told you that one of the number one symptoms that people have with severe hypertension is a migraine-like headache? They have like a severe headache. And how many of y'all have had a headache and like, oh, it's just a headache? You know that? How do you know? When anybody that around me tells me they got a headache, one of the first things I do is check their blood pressure. Except for my daughter.
My husband, he's like, oh, I have a headache. My shoulders hurt, my back, the neck. And I'm like, you better go check your high blood pressure.
And he has high blood pressure, right?
He does, yes, he does.
Yeah. And so that's not something that's uncommon. And that's how with my my children's father, the one that passed away, he had, that's how we found out about his high blood pressure, was having constant headaches. And he'd also feel hot. Like when his blood pressure got real high, his ears would get red, and he'd feel like he felt like his face and his body was hot. Something that's uncommon but not unheard of, if your blood pressure gets high enough, you can experience nosebleeds. And this is a term I want y'all to write down. The medical term for the word nosebleed is epitaxis. Okay? That's something good to throw in the back of your head, because if you hear anybody ever say epitaxis, you're like, what? You know it's a nosebleed. We see that nosebleed because the pressure is so high that some of the vessels and stuff, because this is real thin, a vascular area, they actually burst under the pressure. Patients with high blood pressure have to get it under control. It's not something that they, well, I'll work on that in a little while. No, it's like, oh, your blood pressure's in the high, and this is what we're going to talk about here. It is time to take action now before it becomes severe. All right? And the way that you can do that is by eating healthier, completely just eliminating salt out of your diet. And I've told y'all this, and a lot of people think, ooh, her food must be bland. We don't have salt. It's not something I cook with, because most of the food that we use on a day-to-day basis when we prepare our meals is packed with sodium. You would not believe it. Unless you start reading labels, you would not believe how jam-packed our food is with sodium. And I'm going to call y'all out right here, and this breaks my husband and my daughter's heart. And we have an ongoing thing. And now that I order food by my phone and have it delivered, you know what they try to do is they try to get on my list and add ramen noodle to the list without me knowing. But the thing is, I check it every single time. And you know how many times I've had to delete a box of ramen noodle? I won't let it in my house. Ramen noodle for a serving is the entire amount of sodium that you need per day. And how many people just normally eat one package?
Oh my God, my kid, I have a comment. My kid, my 13-year-old, she loves that stuff. I buy it for her, every now and then. I don't always.
I would limit it 13. If she just has to have it, I'm telling you this seriously, especially if you got hypertension in the family, I'd limit it to once a month.
Okay, thanks. She's like addicted to it. She wants to. I don't know. I'm like, what are you eating that stuff so much? I don't know. I don't understand. Yeah. I have to control her. Yes, she has a bad habit of eating that stuff.
And they don't, and they're not going to understand. You know, something else that has almost as much sodium as that is a box of macaroni and cheese.
And she loves that too.
So, yeah, you've got to be cautious. You've got to look at that. You've got to start. And I'll post up a couple of things. But the sodium recommendations, y'all, if you look at one of the cans of soda, if anybody has, there's usually 60 milligrams of sodium in one can of soda. So, and if you started adding up, well, I've had 3 sodas a day, and then I had this, and then I had that, you would be so surprised that you were past your sodium limit by midday. Oh, wow. Most people are. And so that's why, and some people it doesn't affect, but for the most people it does. And if somebody's a smoker, they gotta stop. Hypertension and smoking, that's a death sentence. Right there, plain and simple. And we already talked about how our kidneys are our filters. Our kidneys control the blood and the pressure, and they are, without getting too complicated, our kidneys and our blood pressure, we have things called baroreceptors. And that's where the kidneys and that circulatory system are just so hand in hand. And if you have untreated hypertension for long, extended periods of time, it can lead to kidney failure, you know? And then vice versa. People who have bad kidneys, a lot of times will have skyrocketed high blood pressure, okay? So those two things go hand in hand. Make note of that. And then this is the chart that I think I've shown y'all before, but I'm gonna place again. This is the American Heart Associations. They are, like, say, if you wanted to know all the answers to the world and you're a religious person, you would go to God, right? Well, if you wanted to know about anything dealing with diabetes, you'd go to the American Diabetic Association. But if you want to know anything dealing about heart and cardiovascular, you're going to go to the American Heart Association. They are the foremost experts. And so this is the guidelines that they've put up. And I will tell you that this has changed throughout over the years, because we realize now that the lower that we can keep somebody's low starting off with, the better. So we like green, right? Green is going to be good. Yellow, that means watch it. This could be your normal. This could be normal for you, but you're close. That means you've got to watch what you do, because you're close to high blood pressure, stage 1. And then there's stage 2.
Yeah.
Does somebody have a question? Hello?
No questions.
Okay. The main thing we have to think of is, when we see these numbers, we remember this color chart. So when you see a blood pressure of 120 over 80, hey, that's good, that's green, right? Or anything under that, that's good. Pre-hypertension, now this is where it gets real hazy, because what if somebody's sitting at 122? Bless you. Well, if they're sitting at 122 and over 78, am I going to be too worried about that? No. What we want to see is we want you to be aware
That's
of,
mine right there.
yeah, that this yellow sign right here.
Yeah. Yeah.
So that's something that, like I said, we'll talk nutrition, and when we start doing that, I'll let y'all know sodium things. And like I said, when you cut out a lot of the sodium, you wouldn't believe how much your blood pressure will drop. Unless it's something genetic, something related to that, then you might be predisposed to it just naturally. Um, Another thing that we don't take into is hereditary. Black people are naturally more at risk for hypertension than other races, and just like Asians are more at risk for certain factors, and the Hispanic culture. You see so much type 2 diabetes, and with my students that I had in Texas, from Mexico, just so many of them with type 2 at a very young age, and it's because of the high carb diet. So certain things are related to race, genetic, basically. So if you know that, like my brother, y'all know my brother's black, and I tell him all the time, he's here, this is his, and I'm constantly telling him. And he's what, 51? He's old. And I tell him all the time, watch that blood pressure. Stop eating that stuff. And when he comes down and sees me, I'm always, I don't let him have salt, and I don't let him eat. He used to eat. He used to be a ramen noodle eater, and I finally got him to stop eating that. So, and he's on blood pressure medicine. He's doing better, and I got him to stop smoking. So we slowly worked on improving it. But yeah, there's steps that you can take. But a lot of times it's the patient. The patient's not willing to make those massive changes to see the results. This is where we see most Americans. Most of your Americans are going to be right here, hypertension. And bet me, when y'all get out on the extern and you're doing blood pressures, that you don't see that 90% of your people are right here. And then when we start seeing numbers like this is a little concerning. And this is where one of the ones I watch that person, and that this is something that they're always at. That's a little different. But to say they're here and then they normally walk in, with this type of blood pressure, and now they're at this, that's something I'd let the doctor know about. Okay, there's a major increase in Mrs. Jones' blood pressure than what it normally is. And then this range, 180 systolic over 110 diastolic, from those two numbers up, if you see anything like that, that's immediate. Notify the doctor, or if it's your protocol, call 911. And what I suggest before calling 911 is wait, notify the doctor, and usually wait 5 minutes, let the patient relax and have time to calm down, and see if it doesn't drop. Because going to the doctor itself usually elevates people's blood pressure. That's called that white coat syndrome. And people are nervous, or maybe they had a long walk through the parking lot in the heat. So give them a few minutes. But I will tell you, if somebody comes in and their blood pressure is 220 over 130, you are immediately going to notify the doctor and probably call 911. Okay? That's not something, it's going to just come down a little bit with a few minutes of sitting down and relaxing. But 180 over 110 after 5 minutes or so might drop to 160 over 100. It very well could. Y'all see what I'm saying? So it's something that you want to maybe monitor, and that's, like I said, it's all going to depend on the protocol for the office where you have. If you have a doctor that's very cautious and doesn't take any chances, their protocol will probably be just call 911, let me know, and let's get the patient on oxygen, that kind of thing. Okay. I'm going to end the lecture today. Let me get roll here, because we're going to be moving from that to hypotension. So I'd like to focus with hypertension. There are several things that I am actually going to load for y'all that I really want y'all to watch. And I'm going to stop recording here, and